morning, good evening, and good afternoon, everybody. I am Dr. Mohit Bhandari, and we are live here with the 29th episode of Virtual Bariatric University. Myself and my team here at Indore in India, we are so glad and honored to have you alongside Professor Fobi, and both of us are hosting these Virtual Bariatric University episodes since a long time now, helping young surgeons and colleagues to learn more about the specialty of bariatric and metabolic surgery. Today we are present with yet a very interesting topic, something which is a common clinical practice, but a lot of questions are raised as to how we manage it when it comes in a post-bariatric surgery patient. We are talking about the gallbladder disease management in bariatric surgery patients. This entire episode is dedicated to management of gallstones, acute chronic cholecystitis, CBD stones, and several other gallbladder and biliary issues which can arise post-bariatric surgery, where in some of the cases where a bypass procedure has been performed, we do not have duodenal access. It's a very, very difficult situation for a patient to be in when a bypass stomach cannot be accessed and there are problems associated with gallbladder and the biliary tract. Ladies and gentlemen, welcome to the 29th episode of this Virtual Bariatric University specifically dedicated to this particular topic. Let's start right away. We have Professor Marina Kurian from United States of America. Marina is a great friend and she is one of the most known surgeons in the field of bariatric and metabolic surgery in US. She's a director of New York Minimally Invasive Surgery Center and PLLC weight loss surgery expert in New York City. Marina has dedicated her professional life to compassionately treat obesity with least invasive procedures possible. She is nationally recognized as a leader in bariatric surgery, featured frequently in media specials and lectures across the country. Dr. Kurian has appeared in media on the Today Show, the CBS Evening News, Dateline, ABC News Radio, Maxim, CBS Internet Radio, People's Magazine, Fox News, and the Discovery Health. Marina has authored dozens of articles and published book chapters in the field of bariatric surgery, co-authored Weight Loss Surgery for Dummies, a comprehensive, compassionate, and very well-reviewed guide to weight loss procedures. Dr. Kurian is the first surgeon in US to be trained on the Orbera balloon. Welcome, Marina. We are so honored and proud to have you, and also to deliberate alongside you to understand about this very complicated scenario. Another great friend from Germany, Sylvia Weiner, one of the most dynamic surgeons from Germany. Sylvia, is an honor to have you. She is the perfect role model for young female surgeons. In 2018, she specialized in visceral surgery and became the head of the bariatric surgery, which soon became recognized the German Bariatric Center. In 2019, Sylvia became the head of the Department of Obesity and Metabolic Surgery, currently leading a team of 30 specialists, including nutritionists, physiotherapists, and bariatric nurses. Sylvia, in addition, is leading the bariatric program at Nordwest and is recognized on the international stage. Since 2002, she assisted her father in organizing the highly successful biannual Frankfurter meeting, and recently she took over as the president of this particular meeting. I had the honor for last 4 years to operate live, and out of those 2 years, I was there in Germany at Sylvia's center to operate live at her beautiful hospital and facility. The first one we did was at the University Hospital with her father, and then now she has shifted to a new facility. It's an honor to have you, Sylvia, somebody who is a role model for a lot of young female surgeons who are deterred to join this specialty of general visceral surgery and thereby a super specialty of bariatric surgery. But you can be an inspiration, and so it's a real honor and a pleasure to have a friend and to have such a role model like you on this particular show. Welcome, Sylvia. Last but not the least, Professor Renee Hilton, Rowe from United States of America. Renee is an assistant professor at Medical College of Georgia at Augusta University Medical Center, section chief of minimally invasive surgery, and director of the Center of Obesity and Metabolism at Augusta University. She completed her general surgery residency at Jackson Memorial Hospital at the University of Miami and then fellowship in bariatric minimally invasive surgery at Yale. She specializes in laparoscopic procedures for obesity, including bypasses and sleeves, and revision bariatric surgery. She is also committed to providing patients with highest standards of diagnosis and surgical management of complex foregut diseases, including achalasia and GERD, diseases of stomach, small intestine, gallbladder, and other abdominal organs. Alongside, Renee also specializes in recurrent abdominal wall hernias, hiatal hernias, and complex laparoscopic procedures. She is involved in numerous research projects involving obesity and is currently serving as the principal investigator on 2 trials in Augusta University. Renee, welcome. You are also the vice president of the Georgia chapter of ASMBS. It's an honor to have you, and you will serve as the president of this chapter in 2023 to 25. Renee, welcome to this show, the Virtual Bariatric University. You are coming on this show, which I host with Professor Fobi for the first time, and it's a real pleasure to have such an accomplished leader in the field of bariatric and metabolic surgery like you. Last but not the least, my mentor, my teacher, and the clinical director of research at our Center Bariatric Services, Professor Fobi, and myself. We once again welcome each one of you to this show, where we're going to have my friend Marina, Sylvia, and Renee, all 3 of them discussing and deliberating on a very complex issue, gallbladder diseases and biliary tract issues after bariatric metabolic surgery. A warm welcome once again. At this time, without any further delays, let's call Professor Marina Kurian for today's very, very important lecture, the gallbladder disease management in bariatric metabolic surgery. Marina, the stage is yours.
Hi, everyone. I want to thank Dr. Fobi and Dr. Bhandari for inviting me to talk about this important subject in bariatric surgery. And I look forward to the discussion with our moderators after, as well as the live surgery that we will be seeing from Dr. Bhandari and Mohit Institute. So my topic today is gallbladder disease and management in bariatric surgery. And just as a background, and I'm sure that those of you who are watching from different countries will have different numbers, but in the US, there's over 500,000 cholecystectomies performed annually, and it is cholelithiasis is present in about 10% of our population, and 20% in age greater than 40, 30% in age over 70 years have gallstones as well. And the female to male ratio is 4 to 1. And you guys remember a lot of this from med school as well, that the risk factors are obesity, diabetes, estrogen and pregnancy, hemolytic diseases, and cirrhosis. And that more than 35% of those patients who are diagnosed with stones will go on to develop cholecystitis and have a cholecystectomy. Asymptomatic patients in general do not need a gallbladder removed, except in special cases, which are large stones, more than 2.5 centimeters, patients with congenital hemolytic anemias. And for us, we see that with sickle cell as well as some others. Or if a patient has a non-functioning gallbladder. And now also the question is about bariatric surgery, whether patients should have concomitant cholecystectomy. And we'll talk about that as well. So how are we doing preoperative testing? And I think ultrasonography is a diagnostic test of choice. It's 90 to 95% sensitive. And it's also important to note that when we do the pre-op testing, that up to 3 to 10% of the patients can have common bile duct stones in those that are undergoing cholecystectomy. So that was actually a rather high number because I don't usually see that in my patients. So it's something to bear in mind. And then obviously we use ultrasonography to diagnose acute cholecystitis, and sometimes we need to use the old favorite, the HIDA scan, to also help us identify if the abdominal pain is really related to the gallbladder. So how about after bariatric surgery? So the incidence of cholelithiasis was in this study, 1/3 of patients followed up for 12 months. And they found in their analysis that greater weight loss and other variables did not increase gallstone formation. And oddly or interestingly, hypertension seemed to be protective in their patient population against gallstone formation. And another study looking at incidence after bariatric surgery, overall rate of symptomatic gallstone was 7.8%, and the mean time for development was 10.2 months. The incidence of symptomatic gallstones with complications in this population was 1.9%, or 2% of the population. And so they found that one of the variables that were important was that if a patient lost more than 25% of their original weight, that this was going to be a risk factor for them to develop gallstone disease. And this is a paper from Dr. Aurora Pryor's group. It's from our New York State database. And it just shows you that the incidence of gallstones and then subsequently requiring a cholecystectomy was 6.5% after banding, 9.7% after bypass, and slightly higher, 10.1% after sleep. Now, I think it's important when we talk about the incidence of gallbladder disease that most of these studies that I just mentioned are not using Actigall. And in particular with this New York State database, what's missing is that element of whether patients are on ursodeoxycholic acid. Sorry, I said Actigall, but it's ursodeoxycholic acid. This is another paper, a recent paper in SWORD looking at the long-term incidence of gallstone disease, and it's from the Swedish obese subject study. And they found that bariatric surgery had an increased risk compared to just obese patients when looking at them for over 20 years. So if you had bariatric surgery, you had a 13.1% chance of developing symptomatic gallstone disease versus 9.2% in the obese population. They also noted that it was greater during the first years after bariatric surgery, and that also this was an increased risk of having the gallbladder removed after bariatric surgery. This paper looked at 202 patients who had bariatric surgery and saw that before any surgery was done, there was a 34.3% incidence in this population of having gallbladder disease. And you see the breakdown, some of it was sludge, but 20% of this was gallstones and asymptomatic. And in this population, when they did the ultrasound preoperatively, only 2.3% of the patients had symptomatic gallstones. Post-op, they were looking only at 146 patients, and at 1 year, they identified de novo gallbladder disease in over 20%, and found also that the cholecystectomy rate for symptomatic disease was 3.4%, and of those, 2% developed acute cholecystitis. They did not see any excess weight loss difference between patients who developed new gallbladder disease and those without. Another study, this is from Keith Gerson's group, and the frequency of cholecystectomy was 10.6% after bypass, 2.9% after banding, and 3.5% after sleep. There was variable administration of ursodeoxycholic acid, but they found that excess weight loss more than 25%, again, was the strongest predictor of whether the patient would require postoperative cholecystectomy. And also they found that the highest frequency was within the first 6 months, but declined by 1% a year after 3 years of follow-up. Yet another study that looks at sleeve gastrectomy patients, and they actually gave one group ursodeoxycholic acid and the other did not have it. And so they evaluated the patients at 12 and 24 months. 10.5% of the patients developed stones in those who received ursodeoxycholic acid versus almost 40% in the group without. And they saw that once daily ursodeoxycholic acid was significantly causing a reduction in the formation of gallstones, and they suggest routine use. Another study, again, looking at a different aspect or different surgery, which is OAGB, or one anastomosis gastric bypass. And in this study at 12 months, they found that in the patients that received ursodeoxycholic acid, that in the group that received it, it was a 4.2% incidence of gallstones, and then in the group that did not receive it, it was 25% incidence of gallstone formation. So, you know, we need to look at prevention because I think we all know what the treatment is for symptomatic gallbladder disease, but the prevention is looking at what we can do. And so in this particular study, and they followed the patients out for 13 months on mean, the incidence of CL or cholelithiasis was 32.5% in the non-treated bypass group and 25% in the non-treated sleeve gastrectomy group. And the treatment was either once daily or twice daily ursodeoxycholic acid. So the once daily group got 500 milligrams, and you see that it reduced it in the sleeve patients to 2.4%, and that in the bypass patients, the once daily was reduced from 32% to 18.6%. An interesting finding in this study is that when the bypass patient was given the ursodeoxycholic acid in a split dose of 250 milligrams twice daily, they had an even greater reduction to 5.7%, which is interesting and probably highlights the fact that there is some malabsorption in the bypass, and maybe giving the larger dose all at once was not as effective at getting the medication into the vial. So again, another study looking at 200 lap sleeve patients, and they were randomized to either having urso or no urso, and 6% in the urso group developed cholelithiasis compared to 40% in the control group. And in this study, they did not find any difference in any of the demographics, and also did not find a difference in excess weight loss at 6 months affecting the incidence of cholelithiasis. This is a study from Della Penna looking at giving ursodeoxycholic acid for 6 months and whether that impacted gallstone-associated morbidity, in patients with preoperative asymptomatic gallstones. So this is very interesting because we're looking at patients that you've already identified as having gallstones. What do you do? So this study looked at giving these patients who you identified as having gallbladder disease before surgery, not taking out their gallbladder, and giving them the ursodeoxycholic acid for 6 months. And what they found is that it seemed to reduce the incidence of gallstone-associated morbidity when compared to all the studies I just talked to you about, so that they feel that this decreases the need for us to do concomitant cholecystectomy at the time of bariatric surgery, because we can give these patients, if they're asymptomatic, we can give these patients ursodeoxycholic acid and help them continue to have a low likelihood of needing a cholecystectomy. Again, going to the, this is a Swedish population-based cohort study, and what they want to look at in this paper was the standardized incidence ratios. Okay, so they call it SIR, standardized incidence ratios. So they looked at over 13,000 patients and found that in the bariatric surgery group, that the number of cholecystectomies, which was 8.5%, exceeded the expected number by over 5-fold. Okay, so 8.5% was was over fivefold what was expected in the normal population. And as well, they found that urgent cholecystectomy for either cholecystitis, cholangitis, pancreatitis, or jaundice was also much greater than expected, and that was at 3.2%, but the SIR was 5.2. And that this peaked 7 to 24 months after obesity surgery and decreased with longer follow-up, so that we would expect, if we did bariatrics and didn't give them urso and just to run the course of cholelithiasis after weight loss surgery, that we would see a peak in the need for cholecystectomy within the first 2 years, but that it would decrease with longer follow-up, as I showed you earlier in the talk as well. Now, in their comparators for what happens after bariatric surgery and cholecystectomy is looking at reflux surgery and appendectomy, and you can see that the SIR, which was 5.5 after bariatric surgery, was 2.4 after anti-reflux surgery and 1.7 after appendectomy. So what, other than doing lock choles, can we do? This is a paper from Mariano Palermo and Mariano Jimenez from Latin America and Argentina. And they talk about image-guided surgery for common bile duct stones after Rowe-en-Y gastric bypass. And what they basically did is a percutaneous transhepatic treatment to reach the common duct stones and retrieve them. And 21 patients out of 1,400 bypass patients presented with choledocholithiasis, and then they included 18 of these patients in this paper, and they were able to extract in 100% of these patients the common duct stones, but they did see that hyperamyloidemia without pancreatitis was observed in 3 patients. So this is an option when you can't get access to the common duct via ERCP, but there are other ways to do that, as I'll get into in a second. So this particular study is looking at, again, the standardized incidence ratio for cholecystectomy pre-bypass, which was 3.42, and then after, at 6 to 12 months, this ratio peaked to 11.4, which was over 4 times baseline. And then at 36 months, or 3 years out, the incidence ratio had returned to baseline. So the post-bypass group demonstrated the increased risk of 30-day post-op complications after cholecystectomy, including reoperation. And they felt that after bypass was much higher incidence of complications after the cholecystectomy. And I personally don't find this in my gallbladder patients, patients after bypass or sleeve or banding or adrenal switch, that I don't see them having a higher risk of conversion, which they found, or reoperation after the procedure. It's been very rare that I found that to happen in my patient population. And it'll be interesting to hear what my colleagues have seen in their patient populations with post-bariatric cholecystectomy. Now, another thing that I want to discuss is a new procedure, and I spelled it wrong. It's EDGE, E-D-G-E, sorry, on the slide. It's EDGE or EDGE, and EDGE stands for, the E is for ERCP, and the I in EDGE is for intervention, so gastrointestinal intervention. So this is a meta-analysis of 1,268 patients, which was 24 studies, and they looked at the success of EDGE, which was technical and clinical success, which was over 95%, compared it to lap-assisted ERCP, of which I've done several through the remnant stomach, which was also over 95% for technical, and clinical success was 93%, compared to balloon enteroscopy ERCP, which was 71.4% technically successful and not quite 60% clinically successful. what this meta-analysis did show that with this EDGE procedure, which I think, what they're doing is they're creating a connection with a stent from your gastric pouch to the gastric remnant. So they are creating a gastric fistula, and that they found that there was stent migration, and they also had some bleeding when they were doing this, a 6.6%. And if they pooled all of the adverse events, they were close to 22% with EDGE, 17% with lap-assisted ERCP, and balloon enteroscopy had the least adverse event at 8.4%, but a balloon enteroscopy was also the least successful. And I think I want to talk to my colleagues and have that discussion about lap-assisted ERCP. So this paper then concluded that the EDGE procedure is better than balloon enteroscopy and comparable to that of lap-assisted ERCP, and that EDGE also has a similar safety profile compared to LA or lap-assisted ERCP, but does have a higher adverse event ratio. So this is a recent paper in endoscopy on 178 patients who underwent EDGE over a couple of years. And again, the technical success was high, 98%. And they did see a fair number of peri-procedural adverse events in 28 patients. 15.7 were mild, and the severe ones, though, were 2.2%. And 4 of these severe adverse events were managed laparoscopically. To our real concern is about creating a gastric fistula and then expecting it to close. So they noted after removal of the stent that there is 10% of those that were sent for objective testing. So this is not, everybody was evaluated to look for gastric fistula. This was 10% of those sent for objective testing were found to have a persistent fistula, and this was 9 out of 90 patients. And so as you see, it was 9 out of 90, but there were 178 patients in the study. And then once they found the fistula, 5 out of 9, so not all of them, underwent endoscopic closure procedures. And in those 5, it was successful. And those of us who have sent our patients for, or done it ourselves, try to close the gastric fistula with endoscopic suturing, know that this actually can, it does work some of the time, but it is not 100%. And that we really need to watch the patients for a longer period of time to see what the success rate really will be. So again, this is just going over that same thing, that highlighting that 5 out of the 9 patients underwent endoscopic closure. One other thing I really want to talk about, especially when we are talking about cholecystectomy, is indocyanine green. And I think, as this study showed, fluorescent cholangiography significantly improves patient outcomes. It's non-invasive. You don't have to shoot a cholangiogram. There's no radiation. And what it does is, if you have the capacity, the fluorescence really improves visualization of the biliary tract anatomy. It decreases the rate of common bile duct injury and mortality. Now, I use ICG on all my gallbladders. I do it to identify the anatomy, but I also do it because almost all of my gallbladders are done with residents, and I want them to visualize the cystic duct and improve the dissection plane for them to see it better. And I think this is a great adjunct. And this is, again, using another study looking at 13 studies. It's a systematic review, and that cystic duct visualization was 86.5% before dissection of Calo's triangle with 2.5 milligram dosage of ICG. So the way I give ICG is I take the indocyanine green and have anesthesia mix it up to 10 cc's, and I ask them to give 2.5 cc's with a 4 cc flush of saline so that, and 20 minutes before, if possible, 20 minutes before I start the case. Otherwise, if you give it when the patient's on the operating room table, by the time you prep, drape, and get your cannulas in, your trocars in, and start the procedure, it will be in the cystic duct and also in the common duct. And after the dissection of Kayla's triangle, then it was close to 97% where you could see the indocyanine green in the cystic duct. Another thing that you can do, which I haven't done yet, but it is great for teaching, is to directly inject ICG into the gallbladder. So, and that helps you visualize any extrahepatic biliary anatomy, visualize the cystic duct and common bile duct junction by fluorescence. And really important, again, for training purposes, is showing you the dissection plane between the gallbladder and the liver so that you don't get into the liver bed if you can avoid it. Obviously, we all like to avoid it. So I want to conclude. I have a few conclusion slides, but this is actually a conclusion from a systematic review on the management of gallbladder disease in patients post-bariatric surgery that was put out by the ASMBS Foregut Committee in SWORD in 2020. So based on the available literature, and hopefully I've shown you this in my talk as well, 1, routine prophylactic cholecystectomy at the time of bariatric surgery is not recommended. 2, in symptomatic patients who are undergoing bariatric surgery, concomitant cholecystectomy is acceptable and safe. 3, ursodeoxycholic acid may be considered for prophylaxis during the period of rapid weight loss. I give urso routinely in my sleeve and my bypass patients for 6 months. And then 4, routine preoperative screening and post-op surveillance ultrasound is not recommended in asymptomatic patients. So my conclusion again is, if you give patients urso for 6 months, you will decrease your rate of cholecystectomy. A BID dose or twice daily dose may be better for gastric bypass. I threw this in, let your patients know you do cholecystectomy, because especially in a bypass or an OAGB format, when you're there, you can check that anastomosis, check the bypass, check your sites for potential hernia. So some of my patients are always like, well, I thought you just did bariatrics. I didn't realize that you did gallbladder as well. But let them know you do general surgery so that they can come back to you and you can evaluate their procedure. And also ICG is a great option, either IV, which I've given, and also trans gallbladder. And then talking about what we need to do when we have to evaluate the common duct, obviously PTC is an option, but lap-assisted ERCP is good, and I do believe it has less morbidity than EDGE. EDGE, which is creating a gastric fistula, is definitely an option. And in the future, EDGE, where you're using the conduit or creating that gastric fistula to do any kind of intervention like polypectomy from the remnant or EUS in a really hostile abdomen. This is going to be very helpful in complicated post-op patients. And I think that it's going to be great. Thank you so much for the opportunity to present.
Thank you. That's a comprehensive coverage of the topic. At this time, I'll start with Dr. Weiner. If you have any comments and questions for Dr. Marina Kurian, I would appreciate it.
Thank you, Marina, for that wonderful talk, because actually I stopped doing routine cholecystectomies, even if they were asymptomatic, maybe like 6 or 7 months ago, because I've learned from my father, as soon as they develop gallstones, you should remove the gallbladder. And then it was hard to convince me that especially after bypass surgery, we can take that risk because especially if they develop sludge, I'm always afraid of, especially having these small stones, of getting a symptomatic situation. Do you routinely do an upper endoscopy with the surgery or previous to the gallbladder surgery, especially in patients which might have like very unclear symptoms? Because I feel that people sometimes have unclear upper abdomen symptoms. We don't really know, and as soon as they have gallstones, I declare it as a gallstone problem.
Yes, I find if they have very classic symptoms of pain in the right upper quadrant that goes to the shoulder blade, that I don't necessarily get an endoscopy, but frequently patients will come in with complaints of mid-epigastric pain. And for that, I always send them for an upper endoscopy just to be sure, especially when I feel like it's not classic and it's not necessarily always food related. So I do have a high rate of sending them off for upper endoscopies.
And what do you think? I mean, if you have people with unspecific epigastric problems and you don't find anything in the upper endoscopy and you have gallstones sonographically, would you remove the gallbladder then in that case?
So I have a long discussion with the patient, right? And I love to hear what Renee does as well. But I find that if I tell them, look, it might be related to your gallbladder, I can't guarantee it. And we used to say this with any lap chole, right? When I was trained, they were like, tell them that 15% of the time they're still going to have pain after, even if we think it's classic gallbladder disease. So I tell them that this might be the reason, but it might not. And I think the patients over time usually come to the conclusion that they want to have the gallbladder out. Now, interestingly, I have a patient who I know has gallbladder disease, but she had just had, she's almost 3 years out from her sleeve. She had had a tummy tuck. She's like, I just don't really want to have this out right now. What can we do? So I put her on ursodeoxycholic acid, and she's been doing okay and not having, she's eating low fat and she's just not having any symptoms. So maybe she will eke out a long-term solution if we keep her on the urso. Renee, what do you do with these patients?
So I think you've already brought up a couple of points that I make sure that I talk about to the patient. First of all, I do tell them this may not get rid of your pain. If it's kind of vague symptoms, and it's not a guarantee that taking out the gallbladder will get rid of it. The other thing that I prepare these patients for is, you already alluded to this, I check for internal hernias while I'm in there. Sometimes these vague abdominal pains after, ruin like gastric bypass, maybe they have a large internal hernia where intestines slipping in and out, they're not going to present acutely. So what I tell these patients is if we're going to go to the OR and the diagnosis is unclear pre-op, I usually will set them up for a diagnostic lap, take the gallbladder out, and do EGD in the OR all at the same time. So I feel like in that case, I've taken out the gallbladder, I go ahead and check the anatomy. If there's an internal hernia, I fix it. And I was always taught if you have a bypass on your OR table, you put a scope down if you can and just check everything out. So I take full advantage and just check all three kind of common places that could be leading to a problem. I did have a question for you about these cases where the gallbladder's a problem and you're going in to do a lap chole on a patient who's had a root-like gastric bypass or a procedure where their foregut is altered. I do either ICG or cholangiogram on all of these patients because I find that the incidence of having polydictyolithiasis is not negligible. And if you miss it postoperatively, getting the stone out, you're really left with only a couple of options, either transgastric, transbiliary, or a knee procedure like EDGE. Do you routinely do ICG or cholangiograms on every bypass when you take out a gallbladder?
I do routine ICG on all gallbladders now that I have that technology. I really love it. And honestly, it really saves me because when the residents are doing the dissection, I'm like, well, maybe we're just, when we say it's just a millimeter difference between where you want to dissect and where I want it. But now when I flip it into the other screen, they can actually see the outline of the cystic duct. There was a paper I reviewed from Italy where they looked at ICG and training. And they found that actually having the ICG reduce the operative time with the residents doing the surgery. So yes, this is a good thing. The problem with ICG is it's not going to show me a common duct stone unless it's big. And I showed you that it was 3 to 10% in the normal gallbladder population that they would have like asymptomatic common duct stones. So I do not routinely do a cholangiogram. I will say that whenever I have done a cholangiogram for patients that had, like an elevated bili, or there's some reason that I felt like, oh, this might be somebody that clearly had something, I have yet to find a stone in that. So I don't routinely do a cholangiogram. I will if there is, and not ICG, I mean like a actual, high-pake cholangiogram, only if I find that their LFTs are really out of whack, or they had pancreatitis or something, then I will do it. What about you, Sylvia? Do you find a lot of common
Actually, we
duct
don't have the
stones?
technique. We're only in Germany, so I'm in a big hospital associated with a university, but we don't have the technique. I would do it if I could.
Okay.
Yeah.
But do you routinely do cholangiogram in
No,
the
no.
gallbladder? No.
Not at all. But
So my follow-up to that then would be, if you find one, Marina, if it's the first time that you say you do cholangiogram, you find a big common duct stone in a bypass, what would be your treatment algorithm while that patient's on the table? Would you do a lap common bile duct exploration? Would you call in a GI colleague to do a lap transgastric? What would be your approach?
Yeah, no, I'm going to take care of it myself, if I can. If I can't, then I'll call GI. But I would just, first tell anesthesia, give them some glucagon, try some power flushes, all those things that you try. And then I would try send a balloon down and see if I can't pop it out that way. It definitely adds a fair amount of time when you're not prepared to do it. Or if you don't do it frequently, it certainly adds a significant amount of time to your to the surgery.
So you talk about doing a common bile duct exploration in that case?
Right, but I would do a transcystic if I could, and if I couldn't, I would just cut down on it and then do it. I think that the beauty of all of us bariatric surgeons is our laparoscopic suturing is quite good. So I can suture just as well with 2.0 as I can with 4.0 or 5.0. So I would just open and close it primarily without a T-tube. Actually, I think it's safe to do that. Obviously, I would drain it if I did that. If I did open the common duct.
I agree completely. I don't put T-tubes. I've only had to do this once. Most of them, like Marina said, if you just give them the glucagon and flush and pop a balloon down, I've been successful in probably like 95% of the cases. One thing I will point out is when you do it this way, you reduce your pancreatitis post-procedure rate considerably. I think it's less than 1% if you do it laparoscopic, common duct exploration versus with ERCP. I think it's still upwards of close to like 10%, even with the transgastric ERCP.
Mm-hmm. I know that Dr. Bhandari has used a transcystic kaleidoscope to approach those cases. Has any of you done any of that?
I did early on in my practice. We had one that I was able to put in, and there's some newer ones that I know at one of the institutions I work at that they have, and I've watched some video of them using it. So that's a great option. But that's if you're trying to push the stone into one, to visualize it, and two, to push it into the duodenum. That might work, but then you still need to use your balloons or send a basket down and try and pull it out that way.
Yeah, I've used one to help guide a basket, but the image quality is so bad on the ones that we use at our institution that I find I'm better with cholangiogram or ICG usually.
Just as an overall picture, do you do your own? I hear from Dr. Hilton that she does her own endoscopy, right?
Yes.
Sylvia, what about you? Do you do your own endoscopy, or do you call in a GI?
Yes, what we are allowed to do, because it's kind of political thing, we do our intraoperative gastroscopies ourselves, which is quite helpful, because I think every bariatric surgeon should be able to do upper endoscopies. But in our hospitals, there's still a political issue going on for like 25 years, because the internal medicine guys don't want us to have us in our pre-diagnostic settings. So in the most cases, they do the pre-diagnostic evaluation, which is quite good, because I don't want to have personally an all normal obese patients the standard upper endoscopy, but I can do it in every case when we are in the OR, and I'm just in the process of training my residents to do intraoperative upper endoscopies, so that they're at least feasible to do it, and also to take care of like bleedings or treatment with endovac or other options. I think we should all learn that and be able to just do it, because we don't need to rely on our internal medicine guys. That's my personal feeling.
Marina, what about you? You had a
Yeah,
teaching
I
institution with lecture.
I will do endoscopy intraoperatively, no problem. I tend to, I just don't have the bandwidth to do all my own diagnostic endoscopies. And as Sylvia pointed out, my GI colleagues will hate me if I did all of them. But when I am planning a revision, I will do it myself, because frequently their notes do not really adequately describe what I'm going to see when I operate. And so usually here in the US, we have to document a technical failure of the original operation. So the GI notes, even when you ask for them to measure and comment, don't always deliver that. So I will do any patient that I feel is undergoing a revision that I need that information, I will do myself preoperatively.
I did not quite understand from the lecture. Are you recommending from the review of the literature that we should use deoxycholic acid in all patients after a gastric bypass?
And a sleeve, and yes, 100%. After any one of these procedures that is going to have a significant amount of weight loss. Now, after banding, I don't do it because the weight loss is so gradual. There was a couple of studies that said that the rapid weight loss was the problem. Others were talking about total weight loss. So I think that if you have them on for the first 6 months and that's it, you're really going to reduce the instance of gallstone formation during that time. And the original study was done by Harvey Sugarman. And as you well know, and it was a great study. I should have referenced it for this, but there were so many recent papers on it that I just, I knew I would mention it either in the talk or in the discussion. And Harvey did a beautiful job, and he used to give 300 twice a day, and I followed that for the past 21 years of practice.
What about you, Sylvia? Do you use it?
Actually, we did do that for like 7 or 8 years ago, and I had the feeling that the people started always vomiting because the tablets are very big, or if they open it up, then it's very bitter. So we had a lot of patients like complaining about vomiting and so on. So what we do actually at the moment is we start the medication after 1 month after surgery, as soon as they are a little bit more trained in eating behavior and so on, and even also the swelling maybe has gone down. But also, to be honest, only in patients who have like sludge or gallstones present, and we feel that it's working well, because what I see a problem is that normally if we give it to the patient, we should adjust it to body weight, and we can't do it with the patient. So we just give a dosage like a feeling, and it's not really like evidence-based somehow. So we do it like that.
I will say, I do what you do, Sylvia. I don't give it right away. I don't even have them take multivitamin the first week because I don't want them throwing up. So I wait a week for the multivitamin, and I wait anywhere from 4 to 6 weeks for the ursodeoxycholic acid.
Okay.
Renee, what about you? Do you use it?
So I do not use it, although I think after Marina's lecture today, I may start, because I have taken a few gallbladders out in early post-op patients. So the new literature is pretty convincing that you should be. So I also I don't give any medicines during the first 2 weeks. So we don't start any multivitamins until they come in for their 2-week post-op. So knowing what Sylvia just said about how big the pill is, this might be something that I wait a little bit longer and consider starting when they're about, we bring them back in for a 6-week RD visit just to follow up and make sure dietary progression went well. Sounds like that might be a good place to consider starting it.
Now
I have one more question, because as far as I understood from the literature that giving it as a prophylactic even in patients who have no gallstones is not recommended, so far as I understood. And what we do also, I don't know how you handle it, so you give it only if your patients have with gallstones previously or in all patients. And the second question is, what about one symptomatic episode with the patient after sleep, because then we go into treatment with the medication and we wait for maybe a second or a third symptomatic episode before we do cholecystectomy. Do you make a difference between bypass and sleep?
So I give it in bypass, sleep, DS, all of those. And I give it to all patients because the incidence of de novo gallstone formation is real. It's 20, one paper said it's 20, almost 22%. So I give it to all those patients. If my patients have had one episode, honestly, I would get the ultrasound. If it's too numerous to count, you get that ultrasound report, too numerous to count gallstones. You're like, okay, it has to come out. Like, there's no way I'm going to fix this, right? So, or if they have one big one, most of the time they have minor complaints when they've developed some symptomatic gallstones. So they kind of like, it perks up here. And then when they're happy and they're doing something, all of a sudden it kind of like, oh, is that my gallbladder? So I find, and maybe it's regional because it's New York, we're all a little neurotic. They're like, I can't take it anymore. I keep worrying that something's going to happen. So invariably, if they've had one good episode of biliary colic, they'll come to me and I will take out their gallbladder.
Okay, as you mentioned, I was part of the multi-center study by Harvey for use of the cholic acid for prevention. One thing that we don't stress about is the fact that patients don't tolerate it very well. There was a high dropout rate in the patients, and the ones who did take it, we had very good results. But the number of people who stopped taking it was significantly high because of the taste and the intolerance. Do you find your patients having that type of intolerance?
I would say that 90% of my patients take it reliably. Some of them want to keep taking it. I'm like, no, you only need to take it for 6 months. We're going to stop. Yeah. But there are some that say, and so the first thing that happens is they have some loose stools. They'll have, and so you warn them, like when you started, you're going to have that. I've had one patient, like a handful of patients tell me that I really need to take it because I just don't like the way I feel. And I was like, well, can you take one? Try and take at least one. And so they usually manage with one, but there's a few that it's very rare that they tell me they just can't take it. And I think it's because we're starting it 6 weeks out from surgery, 4 to 6 weeks out, and not right away. I think that makes a difference in terms of their compliance. And I always tell them, and they all get it, which is very interesting because it's a very American phrase, that I don't want them to be the gift that keeps on giving. I did your gallbladder, your bypass surgery or your sleeve surgery. I don't necessarily want to be the one to take out your gallbladder. I'd like to save you a surgery. So they don't want to be the gift that keeps on giving either.
Now, if you have a patient with asymptomatic gallstones, like you said, you won't take out the gallbladder routinely. But if you're doing a gastric bypass, will you?
Nope.
You wait till they're symptomatic.
They're asymptomatic. If they're symptomatic, I'll take it. But if
they're asymptomatic when they come. So let's say you do an ultrasound preoperatively and one of the findings is multiple stones in the gallbladder before you plan your bariatric procedure. And let's say the bariatric procedure plan is a gastric bypass. What would you do? Still not take it out?
Yeah, I don't take it out.
What about you, Renee?
I don't take it out, only if symptomatic. If they're asymptomatic, it stays in.
Sylvia, what about you?
Same with me, actually. We have been much more aggressive with it in the last years, but it's exactly the same way. As long as they're asymptomatic, I think the literature is very clear. We have to stay away from the surgery. There's no indication, especially if they are still obese. We put them on a higher risk for any kind of complication.
On the other hand, your internist knows you do gallbladder surgery and sends you a patient with a BMI of about 42 who has symptomatic gallstones. Would you just do the cholecystectomy or would you recommend a bariatric procedure along with it? Renee?
I have to assume that if somebody is sending me that patient, they want me to have that conversation with them. So I will have that conversation with them. Okay. Unfortunately, most of the insurances in the United States require multiple month visits. So, the question is, can they wait if they're so symptomatic for that, and then subsequently do the two procedures together. But if they come to me and they have that high BMI, I definitely have the conversation with them.
What about you, Renee? Would you do the same?
Yeah, so because of our insurance limitations, like Marina just said, we're limited. But I feel the same way. If I have a patient with a BMI of 42 in my clinic, whether they were referred for a hernia or gallbladder or any general surgery problem, I have the conversation about weight loss. If it's an urgent gallbladder, I'll go ahead and take out the gallbladder and enroll them in my bariatric program. When they get to the point of completing the program, I'll go back in and do bariatric surgery. If they can wait and it's just gallstones and they occasionally get symptoms, and I'll do it at the same time. Once they complete the program, I kind of leave it up to the patients and how bad their symptoms are. But yeah, every opportunity I see these patients in clinic is an opportunity to tell them about bariatric surgery.
Sylvia, you don't have insurance limitation in Germany. What would you do?
Actually, I mean, if they are sent for already symptomatic situation and maybe having the second or the third problem, I think they first of all have to remove the gallbladder, especially because we always do preparation with the protein-based diet in before we do the bariatric surgery. I'm very keen on like really educating the patients in before the bariatric surgery. So I mean, if it's needed to be done, then we have to do the gallbladder surgery first. In some patients, of course, we can do a combination, but I prefer not to combine too much, two kind of surgeries, because you might be doubling also the risk of complications. And so in the most cases, we do it separately, to be honest.
Let me see what
Very rarely.
See what I can bring Dr. Bhandari in. He just sent me a note that the case he was going to do has a very bad cirrhotic liver. He was going to do a cholecystectomy and he wants to abort the case. Himanshu, is Dr. Bhandari available?
Sir, good evening.
Yes.
Now,
please share.
hi Sylvia, hi Marina. This is an interesting case. So primarily we wanted to demonstrate today a mini gastric bypass, and this patient was evaluated for the same. This is a 144 kgs, 51 BMI, non-vegetarian male. Has severe diabetes with a glycosylated hemoglobin of 9.5, 9.8, pardon me. And it's a very good candidate for one anastomosis gastric bypass at our center, as you can see his profile. But the problem is when I put the scope inside, which was not reported on the ultrasound, they just reported fatty liver grade 2. But when I put the scope inside, can we have the internal view? You can see that this is a proper cirrhotic liver, which I am having here. So you can see this. And then I could see that the right lobe of liver as well is cirrhotic. So what I decided is to change my plan into a sleeve gastrectomy. At the same time, I would like to demonstrate you the upper GI endoscopy. We do all these intraoperative endoscopies. And here is the endoscopic. Can I have the endoscopic picture here? This is a good teaching case for fellows to decide that even if initial workup makes a patient fit for one anastomosis, it can be converted to a sleeve. So this esophagus to me looks okay. I don't see varices here in the esophagus. The Z line is fine. There's no esophagitis. I would say very mild gastritis. There are no gastric varices here. When we go here into the duodenum, it looks fine. I've already done an endoscopy in this patient, so I know this is just for the purpose of demonstration that I'm doing it intraoperatively. But we know that this particular patient has everything made in fit, except for the fact that when we put in the scope, we see all these problems happening. Also, if I may take your focus towards this area, and I can put it to the NBI mode. So as you can see here, this is the NBI mode. I don't see varices here. In the gastric fundus, I don't see varices here in the stomach. It's completely clean. When I pull my scope back a little here in the esophagus, I start to see very mild. You see here, very mild initial beginning of varices, very mild. You can see the columns here. Now these columns, see, beautifully visualized. these are pre-variceal lesions. So these may convert into varices. Now you see this is beautifully demonstrated here, this one. But they are not actively bleeding. I'm talking about this lesion here, if you can see. This is one lesion, not actively bleeding, but on NBI very beautifully seen columns of varices which are about to get developed again here. So I regard that this patient is going to be a very fit candidate for a sleeve gastrectomy. And therefore, while you were discussing, we converted this into a sleeve and mobilized the stomach. Obviously, it's a good discussion that despite workup, when we fail to do a procedure and we change this procedure intraoperatively, what sort of medical legal consent do we take? So we have all the consents. So when Professor Fobi joined us post 2017, we developed an algorithm. In India, we do all 3 procedures: a sleeve, a gastric bypass, and a one anastomosis. And now the insurance also covers all these 3 procedures. So our algorithm for sleeve is very clear. These are the kind of patients who's going to get a sleeve. Typically cirrhotic males. This is child Pugs A. So this is going to get a sleeve gastrectomy absolutely at our center. And these are the kind of patients. It's a strict contraindication to one anastomosis. I would not even do a gastric bypass here because I see some varices there. So that's the question in point as to what 3 of you would have done. I know for sure Professor Fobi prefers a sleeve here because we work together since a long time now, and we know what's the algorithm set at our center. A mini gastric bypass could have been offered to this patient because he's severely diabetic, super obese, somebody who is very much ready for a follow-up. He has good affordability, no issues, very nice compliance. So it's a good candidate for one anastomosis, no GERD, no history of hiatus hernia, as you can see. But the liver, which was on scan, was showing grade 2 fatty liver, turns out to be completely cirrhotic while we put the scope inside. So that's a surprise thrown onto me, and I have to manage it to the best of my patient's interest. If there are any questions, we'd go ahead and discuss till the time I fire this sleeve and finish it off.
Yeah, so Mohit, there's some data when you look at fatty liver that the weight loss will actually improve what you're seeing with the cirrhosis. And so I think if this patient loses a significant amount of weight, you can actually see improvement in that, in the nodularity and the degree of fibrosis that you have. So that's one. And then 2, for this patient who's diabetic, you can offer the sleeve as you're doing, and also post-operatively, even early on within the first, after maybe the first 3 months, give them a GLP-1 agonist like semaglutide or one of those, and that will improve the A1C at the same time as maximizing some of the weight loss. So I would consider doing both of that, and this will help the patient, as you already said, tremendously. My question is there something about doing an OAGB in the face of cirrhosis? Because, Dr. Sugarman, we were talking about him earlier, he also had said to me for many years that, if he had a patient even with cirrhosis and portal hypertension, he still felt that giving them a bypass was the best option to improve their fibrosis and cirrhosis, and it would also improve their portal hypertension. So, if I had that patient, and I have had this patient, and it was for a gastric bypass, I would go ahead and do it. But I wasn't aware that with OAGB, you had to be a little more cautious with that.
Yeah, so 2 very good points made by you. The first one, yes, the nodularity of this patient would improve, and that precisely can be determined if we have had a fibroscan done previously. But there was no fibroscan done. We do not do it routinely to all the patients. We do it only on known cirrhotics here. But yes, it will improve, and I think sleeve gives a very good option to this patient to lose some weight. And as you correctly said, we add GLP-1s to most of these patients on sleeve, where we have to avoid a gastric bypass and do a sleeve because of A, B, Z reasons. We add semaglutide to them. And we do that even on patients who come to us who do not want surgery because of their reservations, but are diabetic and want an endoscopic sleeve. We regularly add semaglutide. So semaglutide is added very early on after the first month to all these kind of patients, as you correctly said. Now about one anastomosis, no, absolutely not. I'm never going to offer one anastomosis to any of my patients who have this kind of a liver because we have done 6,000 one anastomosis gastric bypass, and the initial ones where we did a bypass of around 250 centimeters, we had around 1 to 2% of liver failure in normal patients. And those in cirrhotics where we offered, we had a 80 to 90% chances of liver failure who required liver transplants. So we have a huge data on one anastomosis. It's a malabsorptive procedure, I would say, and the malabsorptive might not be necessarily for patients from United States or Europe, but for India, the patients are pure vegetarian, and even if they say that they eat a lot of non-veg, the amount of actual non-vegetarian food going into them is pretty less. The protein is pretty less. So I'm scared because when we offered this one anastomosis to cirrhotic patients in our series, as I said, almost 90% of them had to go for a liver transplant. And instead of improving the liver, it rapidly deteriorates the liver. And there's been a data published by Institute of Liver and Biliary Sciences here in India at New Delhi, which published data from 10 different centers who did bypass procedures, not necessarily one anastomosis, but even a Rowe. One of these centers from Delhi, which does a lot of these bypasses, on which they offered on cirrhotic patients, had liver failures and had to go for liver transplant quite early on in the stage. So I would say that the data suggests that these patients offered a pure restrictive procedure, a non-malabsorptive procedure, not even a hypoabsorptive, a non-malabsorptive pure restrictive procedure, and they do pretty well in terms of resolution of the nodularity of the liver, the varix, as I clearly demonstrated. This patient is somewhere child pukes A to B, because you could see the varix developing, and that's beautifully seen on the NBI. That's why I did the demonstration of the endoscopy. I would necessarily not offer this patient a bypass also, because I think that even if the bypass is less than 200 centimeters, combining the total length of alimentary and biliopancreatic limb, these patients do not do good in terms of resolution of their liver failures, but come to us with early liver failure just an year or two after bariatric surgery. That's what our data suggests. Not only my center, but there are 3 other centers who does a lot of bypass like mine. So therefore, we sat with Professor Fobi and we designed the algorithm. The algorithm clearly says for Indian subset of patients, we're not going to offer one anastomosis specifically in completely cirrhotic patients, such as this.
Yeah, thank you, Mohit, for this nice demonstration. Actually, funnily, I had 2 cases, the same cases like you just showed us last week. And even, I mean, we do ultrasound in all patients previous to surgery. And sometimes it's really hard to see a difference because you have a fatty liver and you're starting a cirrhosis. And as you said, you need elastography for that. You can't do it routinely. And we also changed for sleeve. Sometimes I'm a little bit worried about taking down the vessels in between the spleen and the liver or the stomach, because I fear that they already have these compensating vessels going on, and I fear that they might get a problem afterwards. But we don't see that. Even also with the bleeding, it's not a problem. Also, you have a longer staple line. So we also changed it. We did some bypasses in these kind of patients as well, just normal bypasses. They went well, luckily, but I can completely follow the argumentation to not do it with
So
the
Sylvia, I very early on used to do a Rowe gastric bypass on severely diabetic cirrhotic patients, but my own data from Rowe gastric bypass on cirrhotic patients suggests that they have a very high rate of liver failure. And I think that may be more endemic to India because we have that kind of a very pure vegetarian kind of a high carbohydrate diet. So I won't generalize this data to the world, but I feel that we have sleeve as an option for these kind of patients who can come back to us. And I think we sometimes we try to do too much. I just as the grace coming to me, I'm starting to feel that bariatric surgery at best is a palliative procedure to abort a very chronic recalcitrant disease. And I think we first need to think about this patient because this guy with this sleeve might lose good amount of weight to qualify for even a transplant with some liver improvement, and would delay his liver transplant for say another 5 or 10 years, depending upon what sort of MLED score he lands up with. But the moment I do a one anastomosis or even a gastric bypass here, or maybe a banded gastric bypass, the nutrition becomes so poor, and we had to do feeding jejunostomies on our banded gastric bypasses, a lot of liver failures. And there's a huge data from our center. So I personally do not believe, I believe it's do minimalistic. And I was more concerned because as you can see, Sylvia, I saw a big varix developing there in the esophagus. I don't want to leave a remnant there which has varix later on, and I'm not able to assess that area. So I would strictly go against a Rowe here in this particular case.
I completely agree. That's what I did also in the last cases.
Well, there is another problem in India which is very salient, which is alcoholism. And people do not openly confess that they drink, but there's a lot of drinking. So sometimes you see some of these cirrhotic patients and they don't stop drinking. And then whenever they have consequences, it's your surgery. So you try to be less invasive. Sylvia, I'll ask you, what if you have a patient who is a cash paying patient, also Marina, and they come in for bariatric surgery and you have that incidental finding of cholelithiasis? Wouldn't it be cost effective to offer that patient both procedures? You do have cash patients, right?
Yes.
Yeah, but I would just do I mean, if they're symptomatic, then I will do the cash pay bariatric, but then I will bill the insurance for the gallbladder.
Okay.
If they're asymptomatic, I leave it alone. And I'll put them on Actigol, and the likelihood of them, I take out less than 1% of my post-op gallbladders when I used to track it. So including myself doing the operation or my patients who did not know that I did gallbladder surgery, then they would go to somebody else. I would still track that, and it was less than 1% because I believe because of the URSO.
Okay.
Yeah, I agree. I probably still wouldn't take it out if they're asymptomatic, just because they may not ever need it out. And the cost of taking it out unnecessarily could be high with complication in that setting. As far as the case in the room today, I definitely agree with doing a sleeve in this situation based off the data that you have in India. I previously operated at a center that was a high liver transplant center. And we did bypasses on these patients in anticipation of them eventually getting a liver transplant. We did sleeves on some of them as well. We largely made some of these decisions based off how bad the portal hypertension was. Because in cases with severe portal hypertension, we found a sleeve to be a little bit more technically challenging and higher risk with the degree of pressure coming from the splenic vessel. So, and I agree with Marina. I've done bypasses on patients very similar to this that have done quite well in the U.S. It may be a dietary or compliance issue. The last thing I was going to ask is, do you routinely take liver biopsies of livers that look like this? And go ahead and send it to your pathologist so that you can stage this patient appropriately.
Yeah, so we cannot take liver. We can take liver biopsies in this particular patient, but we have to take a pre-consent to take liver biopsies. patients like we don't have the consent to take his liver biopsy at this point of time. Because these consents, we were not prepared for this procedure to be performed. But when we put in a scope, we have always taken this consent that we might convert. But that's one of the answers to your question. The second point in India is that we are liable if this patient goes in for a liver failure. The gastroenterologist in India, they have made this opinion that bariatric surgery procedures can cause, or weight loss surgeries can cause liver failure. So I'm a little concerned because usually when we offer weight loss surgeries to patients like this, we want to see more benefit than damage. So that's the reason, why we are a little conservative here. And that's more specific to these cirrhotic patients, where I see an open varix, which you never know. A patient decompensates, and we have multiple varices. I could see columns, 3 columns in more than 4 fields. So I'm concerned.
So, I will say, when I looked at, early on, I was giving some DS talks. I was trained to do DS, and I don't do a lot of it, although I do as a revision, I will do the one anastomosis DS. But when I did original research and looked at the literature, 1 in 500 patients with duodenal switch actually had liver failure. And your point about the Indian patients or South Asian patients who may not be getting enough protein in, I think is really the key point, because the duodenal switch patients that developed liver failure were all related to severe protein malnutrition. And so if you're doing OAGB and they can't make their protein stores or take their intake, then that can actually be the reason why you rightfully are saying not to include cirrhotic patients in the OAGB cohort.
Yeah, absolutely. So Dr. Fobi will tell you that we published this data on. So it's very interesting, which I wanted to share, that we had one anastomosis being done with a limb length of 250 centimeters to 350 centimeters. And then when Dr. Fobi came, we went conservative, because at that time Kamal Mahavar published a paper that even 180 centimeters can offer a good weight loss without too many deficiencies. So we came to 180 as a standard at our center, and we could compare our own data from Indian subset of patients. So around 20% of our patients have albumin deficiency preoperatively. That's a very strange scene. And when we compared our data between 250 versus 180, our rate of liver failures have become negligible when we reduce our limb lengths. So as Marina said, it's the amount of protein which we consume is very less. Even in non-vegetarian patients, if we go and calculate through a diet recall, it would not even come to 0.5 gram per kg body weight here in India. So that's the reason why all of us in Southeast Asia have reduced our limb lengths of one anastomosis to 180 centimeters and a total bypass length in gastric bypass to less than 200 centimeters. That's what all of us have started doing, and we are seeing some good results without too many nutritional complications, too many liver failures. But yes, we are also seeing weight regains, as Professor Fobi was mentioning in last VBUs, that the moment we gone more conservative with one anastomosis, we are seeing a lot of weight regains there. That's why I still prefer a banded gastric bypass, which is my all-time option which I can offer, not to this patient because of nutritional issues. I think Marina said very correctly, duodenal switch, only those patients who had a very defective protein intake had liver failure. And that's the reason in Indian patients. The other reason, Marina, which I think is never highlighted, and which I think I should highlight, is a blind loop syndrome and bacterial overgrowth syndrome. The blind loop syndrome and bacterial overgrowth syndrome in Indian patients with liver disease causes severe diarrhea if you do a one anastomosis. So you do a one anastomosis in an Indian patient who has liver issues and he develops a blind loop and bacterial overgrowth in a one anastomosis. There is, for unknown reasons, severe diarrhea, and that's a double jeopardy. That's a very bad situation, a catch-22, because now you have a patient who has already a defective nutrition with chronic diarrhea, with bacterial overgrowth syndrome, and with liver failure. So I have seen this. I have reversed one anastomosis. Dr. Fobi has seen me reversing them for liver failure. So we know the story here in India. And there's a lot of bacterial overgrowth syndrome with chronic diarrhea, despite doing a very minimalistic bypasses here. So we are going towards the conservative sides, that's for sure. We are moving more towards a very standardized banded gastric bypass. In select cases, we do mini or the one, and obviously sleeve. So these three procedures, all three of them have a set algorithm now, and we have completely figured it out what is best for our patients as far as the Indian and Southeast Asian population is concerned.
Okay, at this time, Sylvia, you have any closing remarks or questions?
I just want to make a comment regarding the liver biopsies. I don't see a benefit for the patient because we see that they have a cirrhosis and it does not help us to get a histology. And I think we put the patient on a risk for bleeding or secondary complications. And we just had discussing it twice. I mean, we can make a documentation in a photograph and we know that people have a problem with their liver and does not give us an implication for different treatment further on. So we leave it in order not to put the patient on a risk.
I agree, Sylvia. We do elastography at our center to follow these patients up, and elastographies, and you can do a true cut biopsies, obviously, but this patient, we don't have the consent. And whenever you take liver biopsies, there can be hepatic duct injuries and bile coming out. So you have to take a consent before you do such procedures on Indian patients. So that's the reason. And I agree, liver biopsy does not provide any special. We're already seeing this patient is cirrhotic. I mean, what else? The information we're going to get, but we need serial elastographies, 6 months with liver function tests, and I would say endoscopies, because I could see varix developing there.
Dr. Hilton, any comments, final remarks? On mute.
No, just thank you, Dr. Fobi, for the opportunity to participate today. It's been a very educational panel, and I've enjoyed seeing and learning about these cases in India. I had no idea that the protein concern was such a big deal over there, but now I'm going to want to go read. So thank you for the opportunity to watch in the OR as well.
Thank you. And our keynote speaker, Dr. Marina Kurian, any comments?
No, I mean, this has been spectacular. I mean, very educational. It's always great to, learn from you. And Mohit, you're doing such a fantastic job. You have such a great team. The one thing I noted, though, was I always tell my residents, because they always want to try and help me on the sleeve to hold it, to clip. I'm like, don't touch the staple line, because everywhere you touch it, it will bleed. And I also wondered if your patient was hypertensive, because it seemed like every time you looked in one spot, it would start oozing a little bit. But I also do this. I clip the staple line for pinpoint bleeders. So it was good to see that my practice is validated.
Good.
Marina, I am the only center. I do a lot of these sleeves, and Dr. Fobi would tell you that the only way, and when Dr. Fobi was doing sleeves here in Indore, he was using the same technique. You can ask him. We never sutured a sleeve line. We just used the clips, and the staple line has, as you correctly said, the residents. I have my assistants since last 12 years now. All my assistants are very trained. So they use a Maryland grasper and very softly they hold the staple line without traumatizing it. And then I go and clip it absolutely perpendicular to the vessel. We have been using this method of hemostasis without suturing. I believe that if you cover the staple line, and Manuel is now here with me and was there a couple of weeks back, and we had a lot of discussion on surgeons narrowing the sleeve by covering the staple line with serosa, and they twist the sleeve by attaching the omentum to it. And he has a lot of experience, and we discussed about a lot of sleeve anatomies created by different surgeons across the world. I can tell you, if you use a clip very efficiently, it's a good method to do hemostasis. It's not a very so yes, you are validated, I can say, and not only me, Dr. Fobi also used the same technique to do sleeves here in India. So I agree with you 100%.
Well, I want to take this opportunity to thank all of you. This session has been recorded. It will be available on the VBU network. And for those who are the residents and fellows, I think you have one thing to take away from this meeting is that Dr. Bhandari had planned a gallbladder surgery along with this, but when he found this incidence of cirrhosis, the chances of having a bleed in a non-symptomatic gallbladder was not warranted, and so that part of the procedure was aborted. And the lesson you take from this is, as a surgeon, don't feel obliged to do an operation. You have to weigh the benefit and the risk of doing the operation, and don't hesitate to back out or to reschedule the patient. If this patient does well with the sleeve, they can always come back for a gallbladder surgery later. Thank you all very much, and we'll see you for the next episode. Have a good day.
Thank
All
you.
right, thank you so much.
Namaste. Namaste.
Namaste.
Good. Himanshu?
Yes, sir.
Okay.
Thank you, everyone.
Thank you. Live broadcast is off.